Open.
Outspoken.
It's ophthalmology off the grid.
An honest look at controversial topics in the field. I'm Blake Williamson.
I'm Gary Wörtz.
All right, welcome to episode 2. Gary and I have been talking to Paul Walton. If you enjoyed that first podcast, episode 2 is the extension of that, where we go into further detail about anesthesia and all the nuances of patients who could potentially be difficult. Gary, I'm excited about round 2 of this. How about you?
Absolutely. Paul had so many good things to share. We couldn't cut off the conversation. We had to extend it. And so we're excited to share this second edition of the Paul Walton podcast. We're so excited. Thank you.
Support for this podcast comes from Bryn Mawr Communications. BMC produces a number of informative podcast series spanning a variety of topics in ophthalmology. Discover a new show at itube.net/podcasts.
I'm curious to hear your anecdotes and wisdom about the two categories of patients that you've identified: the patients who have dementia and the patients who have hearing deficits. These are areas that I've never heard anyone really have a strong opinion on, other than probably put them to sleep. So I'm very curious to hear your perspectives on this.
Right. So to talk first about confusion and memory lapse and dementia, obviously if a patient has a power of attorney designation, that needs to be all over the chart and come right to our consciousness. For us, that's the automatic 1 milligram of Versed, and that's about it. We want to see what we have with the patient, mentally and auditory and everything like that, communications, and then we don't want to impair it. It's very easy to impair it with even a little bit of Versed. So we like a little bit to take the edge off, but when we regret having missed a patient with confusion issues, we're usually doing the second eye whenever that comes around with only 1 milligram of Versed, and it's just an easy coast. And we remember the first case is really challenging. So if in doubt, start light. Less is more with the demented patient. If you know the patient's got dementia, we invite family members to come back. If the family member is the POA or not, frequently the sound of the loved one's voice is really reassuring in the operating room. And again, if you're going to do minimal sedation, we don't want it to be distracting, obviously, but we just have had really good luck with having the caregiver, often a daughter or a spouse, come back with them in the operating room. That's going to vary all over the lot, but we found that very helpful. We encourage it. Never really regret that. So with the dementia patient, you can usually talk a little bit off camera with the family member or the POA and say, do they ever get confused when the lights go down, or, can they remember, or, just to build a rapport with the family member as much as to gain the information. I have a heart for this. I have lost dear family members. I'm older than both you guys by a long time, but I've lost parents and in-laws and dear family members, and been a caregiver in hospice and so forth for people as they get really old and get more and more confused. And yet they're souls and they're sweet people and they need help. And we're not trying to operate, obviously, on cataract patients that don't need our services, but it's a real up game for the challenged patient who really is at home all the time and by herself or by himself, to be able to see things well. So we do a fair amount of this when it's referred, when patients want the surgery. Among the most grateful patients are not the patients, it's the family members. When they see how kind you can be, I need a hanky to keep going here, guys, but this is such a good thing we get to do for people, to help them when they're truly needed, when they're needy, and to be kind to them and help them with their life, and to help them in front of their beloved daughter or their spouse who's just, hoping for some glimmer of positivity for a demented patient. I just find that's among the most happy and soulful and rewarding things that I get to do, is take care of patients that just can't help themselves. So on the sedation, minimal sedation, talk to them, get the family member in there, and try to not startle them. Another thing I'll just throw out there is we use a really wimpy eyelid speculum. We use a wire lid speculum of the smallest gauge, and we use it with the sterile incised drape. But then when we put a drop on the eye, this is for all cataract patients, not just the demented people. But we're trying to do is not surprise people, right? And not have a misunderstanding or a startle. And so if we have a wimpy lid speculum, we call it the bounce. We put an eye drop on and we look for any eyelid bounce. And it could be that they need more sedation. It could also be that they just need another topical drop. But I don't like to do surgery unless the patient isn't squeezing their eye to a wimpy eyelid speculum, because that's how I titrate and that's how I adjust my talk and my hand holding and my drugs and how the case is going. There are some patients who just have a very robust orbicularis. And for those, we use a nesting second identical wire lid speculum, and 1 + 1 = 3. If you need to slip that second lid speculum in because they're able to still, randomly squeeze their eyelids all the way together and get their IOP up, you can just put a second lid speculum in. But I've long ago gotten away from the heavy, geared and locked and clamped eyelid speculum, because I want to know if the patient's not feeling the drop, if they're not feeling the instruments around their eye. So it's another way to not startle patients. I guess to put that out there again in our cornucopia of sedation, patients that have axial myopia, like a 27 millimeter eye, their long posterior ciliary nerve is going to stretch with normal bottle height BSS. It's going to be painful no matter what you do with them with topical or intraocular xylocaine. So we use more fentanyl in the axial myopes, whether they're young patients or older patients. We use lots of fentanyl, and we get so the whole body is numb, including the eye, so that when you stretch the long posterior ciliary nerve, when the pressure goes up to 100 millimeters or however high we have our bottles, they don't jump off the table. So that's really not a problem when the sclera is sclerotic, but when the sclera is thin, because the eye is huge and long and everything stretched thin, fentanyl, we go way more with fent and less with Versed. I don't know if you guys agree with that. Have you found that to be true?
Yeah, I mean, that's one of the biggest things that I'm doing with usually when I notice it most is when it's time for INA. So I've taken the cataract out and I'm going to go remove the cortex. And one of the things I do is, as quickly as I can, move the INA tip underneath the iris, because I know that that iris is gonna pop back and they're gonna say, "Ow," and so I try to break that seal by getting underneath the iris and just lift it up, and everything kind of normalizes between the two chambers. But maybe I need to be giving them more anesthesia, a minute or two before that. That'd prevent all that.
In my case, I found that giving the intraocular lidocaine at the beginning of the case, if I do get that reverse pupillary block, they don't feel it at all. And that may be a function of the IV sedation I'm giving them also. But that's the thing that actually got me convinced to use intraocular lidocaine. I always thought it was like, what's the point? Topical is fine. They don't feel it, but it's the reverse pupillary block that they get. So we just do intraocular lidocaine on everybody. And I've not, knock on wood, I've not had a patient squirm when we've done that.
Yeah, I do sugar cane on everybody, and I absolutely on a long axial myope, like he was saying. I get that. It's pretty routine for me, so I need to be doing something better.
Let's step back for a minute, fellas, and talk about not necessarily the dementia patient, because we've gotten pretty deep into that, or the deaf patient, but other patients that are not deaf and they're not demented, that give us the willies, that give us a hard time, that make us wish that we were better prepared, or it wasn't a smooth day.
Like patients who are on tricyclic antidepressants and a fentanyl patch and benzos, and also oxycodone.
And they come in wearing a Hannibal Lecter mask because they bite.
Right.
Yeah, those guys.
Exactly.
Those guys.
Yeah, tell us how. I mean, I'm curious, Paul. What's the secret there?
Well, these are just a category. I think these will be common sense, but I would want to list them if I were giving a organized talk to some residents or something, trying to pique their interest in sedation. If there are patients that exhibit warning attributes or behaviors, it helps us in clinic, it helps us in our relationships, it helps us in premium cataracts, it helps us in not having complaints, it helps us in relationships with our co-management partners. It helps us with our staff, where we hand the patient off to other staff to take care of them post-op. These are all really important parts of the plywood glue, or the social contract. So first of all, I'd like to say, beware of the impatient patient. The patient who's like, do you know who you're talking to? You know, I'm Mr. Muckety Muck, or I'm Sister so-and-so. Those people are really self-important. They tend to be demanding. It may just be a manifestation of their anxiety and how they act it out. But there's a high level of complaining that goes on, or where they play us off against each other. After COVID, I don't know if you guys have found this, but we certainly have. There are more doctor hoppers and there are more doctor shoppers now than there ever were before. And it's because there's relatively a shortage of specialists and doctors of all kinds. But patients get impatient and they don't want to wait 3 months for a cataract eval, so they go to the most efficient, busiest place. In our case, it's us, I think. It's probably you guys too. But then you get more self-referrals, which is gratifying on a certain level. But these are patients that are unattached. They don't have a relationship. They don't know the name of their eye doctor that they like. They don't want to have an eye doctor that they like. They want to have it over. They want you to be the help and already have the surgery done, and they want it simpler than it is. So I find that the impatient patient is something I want to have my feelers out. I want to know that patient is going to be trouble, and I give them extra time and attention, but everybody in my staff doesn't want to miss that. The impatient patient is their own trip. Very important to not get that wrong.
We have a system. We sort of have a single black ball elimination pact that anyone throughout the entire process of evaluating the patient, if they're treated rudely or if they exhibit sort of these red flags, that they are allowed to sort of raise the caution flag. And, there's a fair number of patients, maybe embarrassed to admit this, but we have found we're not the right fit for every patient. And
Yeah.
we have discharged patients just saying, we don't think we're going to be able to meet your expectations. We wish you well, and we can refer you to another colleague in town, but we just don't think we're going to be able to, get you to where you're satisfied with our level of care. And we sort of leave it at that. Is that something you do as well? Or what are your thoughts on that?
We use red Post-it notes for that. And we're frequently passing the baton, if you will, the patient from department to department, and trying to do it all in a well-oiled machine, just in time manner. And there's nothing quite like a removable red Post-it note that said this patient was waiting for 2 hours, we missed it, or their daughter-in-law is impossible, or whatever it is. But everybody that sees a patient after the first staff member identifies that there's an issue, it doesn't have to be their fault or our fault. It's just that there is an issue. We use red Post-it notes for that. They come off at the end of the day. And very frequently, these very, very difficult patients, the next day they come in, we do same day, next day surgery in most of our patients, but the next time they come in, they're almost apologetic for their behavior. They were just acting out their anxiety, and once they realize that people are going to treat them nice and they're going to go through it. I'd love to do another conversation with you guys about kind of how to recognize and fire patients, if you will. That's a really cool subject. Doesn't have to be what we're talking about today. My short take is I listen to a patient play me off against the other doctors in my office and quote them as saying things that they would have never said, and just stir the pot and try to, construe a misunderstanding. And you can tell this person's just going to be somebody we don't want to take care of. But the easiest way I found to do that is just let them talk. And then I'll say, okay, that's 5. And they're like, what? What do you mean 5? And I said, well, I can count 5 misunderstandings. They're nobody's fault. They could have come from me, could have come from the other doctor, could have come from you. But when I get to 5 misunderstandings, I won't do elective surgery on anybody. You need to find another doctor that you don't have misunderstandings with. You don't have to resolve them. It's just we have this number and it's 5. And so I recite what those 5 are. And I just say, you got to find somebody that you don't have misunderstandings with, but our group won't go forward when it gets to 5, and you can have your money back, and we're not mad. We don't want you to be mad, but you need to find a better fit, because elective surgery doesn't go with misunderstandings, and we can work most things out. But when we get to 5, you've identified 5 specific, lengthy misunderstandings. It just means we need to go our own ways and, without saying it's somebody's fault. And that has just been a way to make it like a no fault thing where they're going to go and you're going to go. But they want to argue and misconstrue and have as much victimization as they can get in order to get more out of you and to get more attention, to be more difficult and be the squeaky wheel. And I'll let the wheel squeak up to 4, but when it gets to 5, that's it. And I don't get red in the face and I don't yell, and they might a little bit once in a while, but this is just a few patients a year. I'd suggest that as a way to kind of try to abstract this a little bit and make it into a number.
It's interesting. Tell us a little bit about how your philosophy on taking care of patients with hearing impairment. I'm curious, as we're sort of getting towards the end of our time. I want to make sure we have time to discuss that because I know it's important to you, and I'm curious to learn.
Or anything else, Paul. I mean, if you in the last few minutes here, if there's something that you had thought about that we haven't brought up, would love to hear.
Patients that are dishonest, that don't want to give an answer to a question, or they give a different answer to the same question, almost they won't look you in the eye. This is a really high risk patient population. It's nothing to do with dementia or deafness, but boy, have those patients. So we go back and we have all of our phone conversations on the recording line, and we go back and get transcripts. And we have a patient we have a big misunderstanding with. We study it as a group. And frequently they're just a furtive person that doesn't want to answer questions or wants to reflexively not give a truthful answer or change their answers all the time. Boy, do you want to run away from those patients in elective surgery. We try to decide if patients are a compliant risk, if they don't seem to, they're in a can't-won't position where they either can't or won't do any instruction in the operating room. Okay, we've addled them with medicine that they have an excuse, but I'll write on the outside of the chart, compliance hazard. If I think the patient kind of wants to be bad or doesn't want to be happy or doesn't want to try very hard, it's not like sending them to hell. It's just passing on that this is a patient that we have to be extra, extra careful with, when they sober up again. Let's talk for a minute about deafness. There's sign language, of course, and there's various levels of hearing impairment. And that language is another form of deafness, basically. So let's just talk about a patient that has an interpreter with them, but we're going to take them into sedation land where their interpreter is not going to be able to help them. They're not going to be able to use sign language. They're not going to be able to talk Spanish or whatever the language is. But I have the interpreter do the forehead tap and the sternum tap. And the forehead tap is look at the light. So if I tap the patient on the forehead, they have to look straight ahead at the light. It's not a language. It's something that they do. And they rehearse it a little bit. And if I want them to look down, mira abajo, if you will, I tap them on the sternum and I ask them to practice looking down. And this is a nonverbal way to get a patient to do one of two things that we want them to do as surgeons during surgery, is either look straight ahead or maybe look down or quit belling and quit, you can't look down and bell at the same time. For those of us that don't know ketamine causes down gaze. It's the surgeon's miracle answer to a belling patient is give them ketamine and they involuntarily look down. So remember that when you're mixing up the secret sauce. So with limited hearing and deafness, a little bit of rehearsal goes a long way. A little bit of sedation. We do not want, my nightmare is a patient that you cannot communicate with that's disoriented also. So keep them as close as you can. If they're deaf, they're usually a high-functioning person that survives in society by using all of their senses and their brain. You don't want to start suppressing that stuff unless you're going to general anesthesia or propofol. So in much the same way as a demented patient, to use a minimal amount of Versed. Do you all know that Versed will manifest restless leg syndrome?
I've learned that.
Yes. Yeah.
It's one of our questions that staff calls when they call patients preoperatively. Have you had any injuries to your eye? Do you take Flomax? Do you have restless leg syndrome? Those three questions will just, make your day smooth. And if a patient has RLS, it's on the outside of their chart. And those are patients that instead of giving them 3 milligrams of Versed preoperatively, we give them 1 milligram and we sit back and watch them. And if they start climbing out of the chair, they can still have surgery that day, but aren't you glad you didn't give them 3 milligrams. And all you got to do is wait for some tincture of time to go by, and you're going to be able to operate on that patient and use the fent or something else. Don't give them ketamine because it'll potentiate the benzos and make their restlessness worse. Then when they come back the next day or for the next surgery, they're not as scared. They're not as wired, and they're not as tired on their second eye. They've learned to trust us. They've had a good round trip. And other than telling them what Gary said, you got to tell them it's going to be nothing like your previous experience. Don't expect it to be the same. They are trusting, and they're just not as anxious. And if they slept better, if this is the same RLS, restless leg patient, slept better before their second surgery than before their first surgery when they were terrified of the unknown, the same patient won't have restless legs. The same patient can have 3 milligrams of Versed. It's almost binary how different their response is, even 2 days in a row. If they carry the RLS diagnosis and they didn't get sleep the night before, versus they went home with their Versed on board and they slept in the chair and they got a good night's sleep and they're coming in the next day or the next week for surgery and they're already happy, then they're just not as anxious and they sleep better. So restless leg, maybe that's the third leg to this stool here, is you don't want to paint yourself in a corner by missing that preoperative call diagnosis, restless leg syndrome. Many people have it, and Versed will unmask it. So you want to use little doses and wait for it to wear off.
Yeah, that's very interesting. Paul, you have a hand anesthesiologist. I have a CRNA who is a leg anesthesiologist. She's like my leg holder. So maybe I need to incorporate some of these techniques into the RLS patients, because that is a population of patients that I've pulled my hair out a number of times over. So appreciate the pearls. Blake, what strikes you in this conversation?
Yeah, so for me, I keep coming back to what he just said, which he kind of said in passing, but this is all towards the goal of having a smooth day, right? And when you talk to people like Paul and you talk to people like Rob and all of our friends who do what we do, all of us know how to do cataract surgery. We're very good at it. And it's really not the point anymore. Yes, we're trying to always get better, but pretty much we know how to do cataract surgery. And so what you quickly find is all these other little tips and tricks to make your day smooth, right? To make your day boring, right? In a good way. And when you listen to Paul talk about it, the level of detail that he's gone in, you can't do that unless you can't understand those nuances unless you've been there, and he's been there for a long time doing this. And I think it's really helpful that we have the opportunity to learn from him. And there's no small thing, there's nothing there that's not useful in some way about mitigating the war stories, horror stories. That's what this season's all about. And I think that very much, on these podcasts here with Paul, we're talking all about how to prevent that from ever having started in the first place. And I think it's been very, very useful.
Yeah. And Paul, like we were talking before we got on and started recording, these are the kind of conversations that this podcast was made for. You might not ever hear a podium presentation in a way that gets to the heart of these little nuanced issues like you would if you're standing out in the hallway saying, hey, what are you doing for sedation? Or what are you noticing? And these are the conversations that when you have someone with Paul's level of depth of experience, he's finding these outliers and he can tell you how to make your day smoother for these cases that might be a nightmare. And so even though we've not talked specifically about, horror stories this time, I think this podcast in particular is going to help a lot of surgeons prevent the horror stories and prevent the stress, and may prolong a few careers because of the wisdom that Paul has shared. So with that, Paul, we just want to thank you so much for being willing to come on. You're always welcome to come back, and we appreciate what you've done for us tonight and for the field in general. So with that, thank you so much.
It's a pleasure, and thank you for making me feel so welcome, fellas.
Anytime. See you next time. Ophthalmology Off the Grid. Bye-bye.
Thanks for listening to part 2 of this discussion with Dr. Paul Walton and our hosts, Drs. Gary Wörtz and Blake Williamson. Tune in to future episodes to hear more horror stories from top ophthalmic surgeons.